Invite Dr. Ronnie George for the session on normal tension glaucoma. Sir will be discussing on diagnosis, management, and diagnosis, investigations, and management of normal tension glaucoma.
So good morning, and thanks, Dr. Roshni, for making me part of this. So I'm just going to speak to you shortly about the collaborative normal tension glaucoma study. This has been alluded to before also. So essentially, they took 140 patients who were considered to have progressive NTG, and they divided them into treatment or follow-up. And they had at least 10 intraocular pressure readings on these patients, and none of them, there was not even one reading more than 24, and at least 50% of the readings were less than 20 in each patient. And what they found was, compared to 20% intraocular pressure reduction versus follow-up, definitely the people who were treated had lower rates of progression. And at 5 years, 80% of the controls were stable as opposed to 40% of patients who were not treated. So what this tells you is that treatment definitely helped, but it also tells you that 60% of untreated NTG did not progress over 5 years. So a lot of the NTG that we see need not necessarily be progressive glaucoma, and that's the reason I think she put this topic. So there are a few concerns with the NTG, and the main concern here is there was highly variable progression in the untreated group. So you had two lots. You had one group which progressed very rapidly, and you had one group which did not progress at all. And it's important for us to be able to distinguish these two and to look at some of the factors which we need to consider. So why don't we treat all? I just told you why we don't treat all, because not everybody progresses. And keep in mind that NTG is very often a diagnosis of exclusion. And what you need to exclude is the confounders and the differential diagnosis that can happen with NTG. So the most important thing when it comes to a diagnosis of exclusion is a careful history and a careful clinical examination. And a few investigations which you can do if you don't find anything on the history on exam. So I'll share with you this 23-year-old lady. She's actually one of my optometrists. And they were fiddling around with a new machine, and they took a picture. And this is what her vision was and her intraocular pressure was. And you can see there's a nerve fiber layer defect there. And it's more clearly visible here. You can see there too. Her office diagonal was okay, Pachy was all right. But when you ask the history, turns out that she had mitral valve prolapse. And her blood pressure before she was started on treatment was 100/70. She was started on a beta blocker, and her blood pressure was dropping to 30 and 40. And she was having fainting episodes. So what she's had is a small disc infarct with an associated nerve fiber layer defect. So a lot of the confounders that you see in NTG is because of optic disc hypoperfusion. And why does this happen? This happens because if you look at the mean ocular pulse pressure, it's 2/3 into the mean arterial pressure minus intraocular pressure. And anything which causes a decrease in the blood pressure can reduce your ocular pulse pressure. And there is enough evidence that this is a problem because of two reasons. One, your intraocular pressure increases when you sleep, and your blood pressure drops when you sleep. So this combination can reduce perfusion quite significantly. In fact, 10 to 20% of blood pressure drop at night is common among normals and in most hypertensives. These are called physiologic dippers. When you look at nocturnal blood pressure and glaucoma progression, and you look at these patients who had a 24-hour ambulatory blood pressure monitoring and looking at visual field progression over 7.5 years, what you find is that among people who dip, almost 50% progress as compared to maybe 1/3 of patients or 1/4 of patients among the non-dippers. In another study which looked at the effect of nocturnal blood pressure reduction on circadian fluctuation on mean ocular perfusion pressure, they divided them into non-dippers, dippers, and over-dippers. Over-dippers are the ones with the black bars. And what you can see here is the over-dippers are the ones who had the worst mean deviations over time. So these are the patients who are crashing, whose blood pressures are crashing at night. And you'll be surprised if you ask for a 24-hour ambulatory blood pressure, you'll sometimes see recordings of 30 and 40, 1 o'clock, 2 o'clock in the morning, sometimes with even reduced cardiac rates at that time. The other thing in the history that you need to ask is whether they have had any history of steroid use in the past. And this is something which is rampant in our country. And you'll find people who have been using steroids for 3 years back, for 3 years continuously, and then stopped it. And now you're seeing damage and you attributed that to NTG. So if you have any history of systemic disease where you suspect hypotension could be an issue, consider 24-hour ambulatory measurements, Also take a history of significant blood loss. A traumatic pregnancy can sometimes be a reason for a disc infarct if they've had massive blood loss at that time. The other thing that you need to keep in mind is sleep apnea. And if they have any history which is suggestive of sleep disorders, it's worth investigating. And keep in mind that not everybody has a short, thick neck and is obese. You can get sleep apnea in people who look slim and absolutely healthy too. What about the non-blood pressure cause of hyperperfusion? And here among them, like I said, it's sleep apnea, because hyperperfusion is not an issue here. What is happening over here is reduced oxygenation to the optic nerve because of reduced oxygen uptake at night. I'm not going to talk too much about this except to show you this meta-analysis on sleep apnea. This is of all the studies put together. In NTG, you found that people with sleep apnea had a 3 times greater risk of having NTG. So studies have fairly clearly shown that sleep apnea is a risk if you have a history, if you have unexplained progression, or if you have somebody where you are eliciting, you're not comfortable of the way the disease is behaving, it's worth considering a sleep study. This is the other thing that we sometimes look at, the other reason for hyperperfusion, and that is because of vessel occlusion. So the carotid Doppler is one way of screening for it. Unfortunately, what happens is when you do a carotid Doppler and you see a block of, let's say, 10 to 50%, and you send it to the to your interventional cardiologist or whoever, they are not interested. They say this is nothing. Less than 70-80%, they're not even bothered. But when we looked at our own data of all the patients that we sent for evaluation, you find that among the normal tension glaucoma group, about 11% of patients had a block of more than 10%. When we look at glaucoma suspects, there's only 1% who had that. The population prevalence of any degree of occlusion on the carotid Doppler is about 3 to 5%. So in glaucoma, you're seeing almost double that. See, what we are seeing here is much more distal to what is going on close to the optic nerve circulation. So we don't know. So this may be just a symbol of sign for them, for us to encourage them to put them on anti-cholesterol medications or whatever else. But it's something that we need to keep in mind. The next issue is it really normal tension glaucoma? And this is a problem with intraocular pressure. So if you look at IOP, this is a study that we did using 7 different instruments to measure intraocular pressure in each person. And these graphs show you what is the difference in intraocular pressure that we recorded with the appellation tonometry versus each of those instruments. And you can see how variable they are. You're getting a difference, at a pressure of about 14, you're getting a range of plus minus 6, plus 4 to minus 6, depending on what instrument you use. So if you're seriously looking at NTG, make sure that all the intraocular pressure measurements are with a Goldman appellation tonometry and not with an NCT or anything else. Get enough measurements, but keep in mind that our measurement variability itself is significant. The second issue is we are looking at patients during office hours most of the time. And if you look at this study, you find that most of the time, a good proportion of time, about 30 to 40% of time, the peak intraocular pressure occurs outside of office hours. So somebody with 18, 19 who you think is NTG may be going up to 30 at night and you will not pick it up. Also keep in mind that if you're getting intermittent intraocular pressure spikes, like if you do Shirshasana or if you're doing any type of Valsalva maneuver, that can be one of the reasons for intermittent intraocular pressure spikes which are causing progression. So this is a young gentleman whom we saw, a young glaucoma suspect, family history of POAG, vitamin B12 deficiency. His intraocular pressures were like this, and you can see those inferior nerve fiber layer defects there, bilateral nerve fiber layer defects here. This is his right eye. Visual field staying absolutely stable over almost 10 years. OCT is also more or less stable over 10 years. Showing a little something in the macula at that point. This is the left eye, and you can see he's got much more well-pronounced biaquate nerve fiber layer defects. Yeah, I think, no, this was 10 minutes. yeah. So this is, he had these sort of superior defects and some few scattered inferior defects over there. And what you're happening there, that's his macula, which is showing worsening. And that's his GPA on the NFL, which is not showing too much. But now you look at all his intraocular pressure readings, and you're seeing that he started to spike 22, 24, 26 with time. So this is somebody who we thought was basically NTG's part of the spectrum, while he's actually the POG part of the spectrum. And a few years down the line, about 3-4 years back, his father came to me, and his father is a classic ocular hypertensive with pressures of 28 and 30, but no defects. So this man, we got confused because he was young, not really POG, not really NTG profile. He was a very strict vegetarian, very low vitamin B12 levels. So B12 levels can sometimes also cause these field effects. Of course, he stayed stable for years, but now we are being a little bit more aggressive with therapy. The other thing that you need to remember is that very rarely young patients with NTG, progressive disease, can be because of a genetic mutation. So OPTN or TBK1 mutations can sometimes present with progressive disease. You can test for OPTN. TBK1 is a little difficult to test for. So but this is rare. It is like 1 to 3% of NTG. NTG fortunately is not very common in the country. So I am yet to see more than 1 or 2 patients with OPTN1 mutations. But it's something that you just need to keep in mind. And this is a family which has been the first family that was reported by John Fingert and others, where they had this, pretty strong progression in the family. I'll also share with you this slide. This is something which is looking at so what you're looking at, these are the genetic loci that code for intraocular pressure. And you're trying to see which are the loci which are associated with primary open-angle glaucoma. And when you compare the loci for POAG with the loci for NTG, you see that it's almost the same. So keep in mind that most NTG is part of the POAG spectrum. Our job is to identify the ones which are those low eye pressures, which are progressing in spite of everything, or the ones where there are systemic and other risk factors which might help. So generally lowering intraocular pressure helps to slow progression in most patients. And the treatment of choice is the prostaglandin followed by surgery. But you can have different susceptibilities to intraocular pressure. So some of these patients are very, very IOP susceptible. Keep in mind ocular blood flow and see what you can do about that. Investigate them if required. The other confounders, the ones that we worry about, are basically these. The ones who are showing vision loss, the ones where some clinical findings are not matching what you're doing. So here you're seeing a disc which doesn't really look glaucomatous. It's a large disc, large cup, but there is some temporal pallor. And this patient was treated for glaucoma for 5 years with normal pressures. You do a field and you see a classic midline defect, and he's got a pituitary adenoma. This is not uncommon. We see it all the time. So if you see anybody with vision loss is not typical of glaucoma. If you see somebody with pallor in excess of cupping, and if you see any defect which is even few points which are close to midline, nothing else going on, investigate them. It's well worth it. Even if your false negative rate is high, please go ahead and investigate them, because we can't afford to miss these. And I'll finish by showing you this slide again. So this is that lady who had mitral valve prolapse. This is what she looks like now in the right eye. This is what the left eye looked like at that time. This is what the left eye looks like now. You can see that superior defect. You can see that on the OCTA and on NFL imaging. The mean deviation looks absolutely stable, but you look at the visual fields. She's got a superior arcuate in one eye and an inferior arcuate in the other eye. And this is the 10-2, which is showing defects close to fixation. I didn't treat her. I was following up in between, and you can make out that both of us took it easy, and she also didn't come for her checkups. NFL defects. Intraocular pressures. This is 17, 18. You are starting to see a couple of peaks. And that's the other eye. So I suspected NTG, started her on vimetoprost. After that, she's been stable. So why did she progress? Was it a missed NTG to start with, or did the vascular insult increase the optic nerve head susceptibility? We don't know. But we achieved an almost 40% reduction with the prostaglandin, and she's doing well after that. So the question here becomes that you need to take a detailed history. Keep in mind that most NTG is pressure sensitive, and progressing NTG in spite of a good intraocular pressure control is somebody who needs further assessment, and have a high index of suspicion in non-typical cases. But even the ones where you're convinced it's not NTG, keep them on follow-up, because sometimes they'll surprise you. Thank you.